All right, if you have questions, please come to a microphone and state your name and affiliation.
Good morning. Laura Fenimore, President of the Oncology Nursing Society. Thank you to the panel for a very thought-provoking session. My question is for Brenda, Nevidjon, and the rest of the panel. I am a faculty member at the University of Pittsburgh. I teach doctoral students about leadership, but was very interested in your statement, Brenda, about wasted energy, because as a faculty member, I recognize that we have this thought that we offer interprofessional education and that we encourage interprofessional education, but frankly, I don't see it happening. And in terms of wasted energy, I think that's an opportunity for us to tap into the resources that are available in every school of a health-related profession to share our collective knowledge. But what are the barriers to that happening, to the panel? And do you have examples of places where it is working?
Wow, good question.
So she's my boss, so I have to answer this, and then the rest of you can weigh in. Actually, there are, and I'm trying to remember whether it's the University of Michigan or the University of Wisconsin. It's one of those upper states, sorry if any of you are from there, that they have a really robust interprofessional education effort and how the professions work together. What I can tell you is my own experience as faculty at a school of nursing, and it was at Duke, and where we attempted interprofessional education with medicine, the physician assistant program, the physical therapy program, and the nursing program. And the stopper right from the beginning, if you can believe this, was we all were on different academic calendars. And because we were health professions and not the university side, which has a standard academic calendar, we had some liberty in terms of what our academic calendar was. And trying to come to agreement on how we would find a compromise in the middle was, and it never really happened. So what we had was more the option, more the elective kind of way of doing that. And I participated as faculty in two initiatives, actually, that we did. One was around disaster management. After 9/11, some of you may recall, if you were in academic organizations, big push in terms of disaster management. And again, that was done outside the standard curriculum, but we brought all four professions together, and for about 5 years did do intensive with mock simulation, even with those artificial blasts and things like that. And the other was a series throughout the year that didn't depend on anybody's academic calendar because it was an evening program, and we fed the students. And it was casework together cross-functionally, and we had standardized patients. In both situations, what I will tell you, that the biggest learning that the students had, and we heard this time after time, was they began to understand the other profession. They had no idea why, a medical student clearly said, I had no idea why I would ever make a referral to a physical therapist. You know, they were surprised to learn the education of PAs was very similar in some of the coursework, that when you were looking at certain of the science courses and all. So from that perspective, as well as them learning the content, it was very rich. And I think that as we look forward to shortages of faculty across disciplines, if you're teaching an anatomy course, you know, why don't we put all the students together and you share the wealth of your anatomy faculty as opposed to having 4 or 5 different versions of an anatomy course? Or why don't we use online more, where students go to modules to flip the classroom so they do more work outside the classroom, bring them together with faculty. So I think there are some solutions that can be done. But boy, if you don't get the buy-in of how you do this, and as we know in academia, faculty own the curriculum. And they have a big, big, powerful voice about how much they're willing to do and when they're willing to do it.
Any other comments from the panel on that question, Suanna?
Yeah, sure. I'll just say as well that I think where we have seen changes is really in areas where policies have focused on the high cost areas. You know, and one focus area is on hospital readmission. And, you know, the 30-day rule going into effect, you know, in hospitals. And I think part of that is, you know, I think, Brenda, your point about people not knowing what the other, you know, right hand not knowing what the left hand is doing or knowing what services are available. I think that's really changing somewhat. I know I have a friend actually who just graduated with her DNP, and I was talking with her over the holidays, and she said, I have the freedom to go into someone's house and actually help them, you know, figure things out, you know, help them figure out how to pay their bills, how to, you know, schedule someone to come over and do X, Y, or Z. And that's what her role is. And it's, you know, I think trying to bring those services to people where they need them, it's kind of bizarre because in some ways it's like going back to, you know, the old model. But, you know, maybe it's, you know, sort of a pendulum effect of, you know, we knew things that worked before, and maybe returning to some of those is helpful too.
Larry?
I think, you know, one of the historical problems with both medical schools and nursing schools is that the curriculum, which is a necessary part of it, has been very focused on basic biology, the pathogenesis of disease, you know, pharmacology, all the things that we need to learn, but very, very little in the issues of what we've just been talking about over the last few hours, and how that translates into what your life is like when you actually get out there and practice. And I know in the medical schools that I've been involved with, this has been a problem, and I think Brenda mentioned that, you know, it's the faculty who drive the curriculums. And, you know, and frankly, many of the faculty who drive the curriculums don't go to clinic, you know, and don't manage the inpatient teams. And they do a wonderful job teaching some of the things that both our nurses and physicians need to know to be good at their profession, but they're missing, I think, some of these other important thought processes and skills.
I think we heard from Otis that the new science is getting people the science we already know. So maybe that interprofessional education needs a different curriculum. Next question.
David Morris, employed by SSM Health, member of ASCO, and noticed that stakeholders were ASCO and ACR that also represent radiation oncology, and we are oncologists. This entire morning, I have heard nothing about radiation oncology, with the exception of radiation-induced hypothyroidism and radiation causing cancer. Three things that I'm seeing right now, and I would like for some discussion from the task members who've been active looking at radiation oncology too, is one, we still have cancer disparities and we are not meeting the needs of our cancer patients right now. One of those issues is location of radiation oncology facilities. Another issue is the coordination of the care. There are efficiencies, at least with radiation oncology research that we have done, to shorten the course of therapies. Research wasn't on that last list of activities to improve the efficiencies for care. So I would like for people to comment about ways they can see in the other oncology professions for efficiencies, and I would like to have the colleagues comment on where radiation oncology fits into the oncology care force.
Randy, maybe I can, so thank you for your comments. And as the co-chair of the workshop, I must admit I've had a few moments of anxiety over the last couple of weeks that we haven't focused on individual professions within oncology. And frankly, we haven't, we do have ASCO here with Suanna and ONS and so on, but A lot of what we've said is not specific for medical oncology or radiation oncology or surgical oncology or, frankly, pathology and imaging, all of whom have their own struggles in trying to meet the care demands. And as you suggest, all play their own role, not only in the disparities of cancer care outcome, but also in managing the load of cancer patients. And so I think your points are very, very critical. And we've struggled some with that in my own institution. In one of our disease groups, where the medical oncologist really could not manage the intake of new patients, we made a decision that those patients would be seen by the radiation oncologist first, even if systemic therapy was going to be the ultimate direction that that patient was going to go, and not radiation. And so we are a team in the best of circumstances, and how we work as a team is going to be critical. And I worry a little bit, and your points I think are good, that we're not spending a lot of time in this workshop on some of those issues, and I apologize for that.
In regards to availability of radiation oncology, there's some very interesting maps that have been published, and there was actually an ASCO, American Cancer Society, publication about 2 or 3 years ago that talked about the availability of radiation oncology and how there are certain areas of the country where people literally a large portion of the population lives greater than an 8-hour drive to a radiation therapy machine. Also, I'll note that I'm a little concerned that there's too much emphasis right now on proton beam therapy, which is incredibly expensive, and in most instances where the studies have been done has not been better than conventional IMRT for patient outcomes. So those are all important issues to look at. And we could also talk about problems in pathology. There's huge pathology disparities in the United States geographically. There are also huge disparities in virtually every other specialty out there.
Dr. Brawley, as a follow-up question, you set us up nicely this morning with a heat map that showed the disparities state by state in terms of outcome. Mm-hmm. You mapped that to high-risk cancers, a lot of the ones that don't do well, like lung cancer, liver cancer, kidney cancer. And now and some of our speakers talked about mapping those maps to decreased nurses, decreased APPs, decreased medical oncology practices. Dr. Morris now added decreased or lower radiation oncology practices. What solutions can you suggest that would support and train the workforce when we're looking for different solutions for different parts of the country?
Yeah, I hesitate to say this because of that slide with the Addams family, but the big word that I would use would be medical infrastructure. The states that have the greatest disparities are the states that have invested the least in terms of medical infrastructure. I would also note that the states that are the last to expand Medicaid are the states that have the greatest disparities. One of the states, the state that was the first to expand Medicaid, Massachusetts, Romney Care, really has some of the lowest disparities. And by the way, I started my career doing black-white disparities. There are no black-white disparities in breast cancer or colorectal cancer in 6 states in the United States nowadays. And they all happen to be states that are primarily in the north or northeast. There are certain states that have much more of an interest in access to care for all people. There's certain states, those states also have more of an emphasis, I think, on education and on investment in medical infrastructure. And I think you would find that there's certain things other than medical outcomes for which there are going to be differences as well.
Thank you, Dr. Brawley.
The other thing I was
Suanna.
just going to say, I think, because I appreciate the last question and comment was, the thing that we don't do very well from a research perspective is actually research multimodal care. We're really good, and I can say this, I guess, because I'm from ASCO, which I think primarily represents hematologists, oncologists. We're really good at drug research. And that's because we've got drug companies who fund it, and we're not very good at research that involves, procedures and big, expensive machines, and because the model is different. The model on that side is buy the machine and then use it, as opposed to putting the money up in the pre-market work that helps bring a new therapy to market. But I think one thing that we're also really bad at is figuring out what's the optimal dose for something. And I think you all have been in the radiation oncology field have been really excellent at looking at different dosing schedules and helping look at things from sort of from the patient's point of view. And I think that's really important. And it's really, I wouldn't earn my ASCO paycheck if I didn't mention that a lot of this research, goes on at the National Cancer Institute. That's where this research happens, the research that's really important to clinicians and to patients. And unfortunately, it's also the research that's often, under jeopardy, when it comes to looking for research dollars. So I think these are the things it would help to focus on, and these things are happening, but they're probably not happening as much as we'd like them to.
Brenda, did you have a comment?
Yeah, because I'm going to come at it from a little different thing that you said there about gaining efficiencies. And I think that when you talk about gaining efficiencies in any clinical setting, it's threatening. It means change. And people get comfortable with how they've done things. And if they've been in a career for 10 years and always done it a certain way, to think that, oh my gosh, now I've got to change, the resistance can be very, very strong sometimes to that. And yet, I think in any clinical setting, you can find that staff may not be being deployed to their full capabilities or the scope of their credentials, but that is some of what happens in terms of gaining efficiencies. You've really got to take a look at the workforce. One of the things that I always cringe about is when we see registered nurses in an ambulatory setting basically rooming a patient, and all they do is bring a patient in and maybe put them on the scale, take their vital signs, and then leave. And the moment has been lost where that licensed professional could be doing so much more. So I think all of our clinical settings, you have to take a hard look at yourself.
I'm going to kind of work
Yeah.
right off of that.
Use the microphone because
Oh, you're right.
I'm going to work off of that a little bit. It can be done. The University of Pittsburgh implemented through their entire organization for radiation oncology, shortening the course of therapy for breast cancer. They did it systematically. They had a plan. I don't see that can't be done in any of the specialties or any of the fields. There are other geographic issues. You set up a radiation oncology facility, it's being set up in a place that's going to pay the machine. And that leads to cancer disparities, because if you're 50 miles away, you're not coming. And as Dr. Van Houten mentioned, the largest cost, and it affected 90% of people, was transportation. So,
And we hear that transportation from different advocacy groups when they survey their respondents, patients. Transportation is the number one issue consistently from our patient advocacy groups. So the other thing I would say is Virginia Mason in Seattle did major, not oncology, I mean, it wasn't just oncology, and the book they put out about how they increased efficiencies, so quicker access for patients, better throughput, and all. So, yeah, it's doable, and a lot of places are doing it. So thank you.
Next question. Oh, you're not waiting.
I'm happy to, but I think yeah.
Oh, I'm sorry. I didn't see the other side of the room. Hi.
Hi.
Would you kindly state your name and affiliation?
Hi, my name is Mary Jackson Scroggins, and I'm affiliated with the IGCS and my own company, which is called Pinky Hugs.
Thank you.
Hi, I'm a patient advocate, a 22-year ovarian cancer survivor, and so many things have been said that I want to respond to, but I'll start with the one that someone asked if patients and caregivers really want to be involved and so on. I think the question isn't whether they want to be involved, it's how they are involved, and that they be involved in a meaningful way, and that they not simply be called when it's time for implementation, but they be a part of that planning. And I know everybody says it and everybody shakes their heads because it's real and it's true and it's correct. However, there is a way to do that, which means that you treat patient advocates and their families and those people who are willing to advocate for themselves and generally for others as well, that you treat them as equals. And I say that, and I know that again, people shake their heads, but that's not what generally happens. And I think we have to set up a new paradigm for how we work with people who are non-health professionals per se. And so most people do want to work with you. They don't want to work, most advocates or most patients cannot do that when they're in treatment so well necessarily, but almost everyone, that probably isn't true. Many people have others who are willing to stand in for them and who want to do so, but you really have to ask them. And the other thing that I think is important is that we make sure we just don't ask people who are in the community, who say they want to represent a community, but you in fact look for people who are actually a part of that community, grassroots people who really know what's going on there, not simply through study, but through their actual lives.
Thank you for those important comments. Courtney, do you want to address that, please?
Well, I agree with you. I'm also not a clinician, so it's easy for me to say, but I definitely have worked hard to engage caregivers and patients as we design our research studies, so very Picoria-esque model. We have veteran and caregiver engagement panels to talk about what are the skills gaps they have, how can the providers better include them in the care team. But I think we can also draw from advances in research that are being done at Hopkins. So my colleague Jennifer Wolf has really worked to understand from the patient's perspective at that first visit, what role do you want your care partner to have in your encounter through the cancer journey? And I think it has to be certainly driven by that person needs to be at the center. They need to tell the care partner what they want, and then that care partner needs to say, well, this is what I want, and have sort of a negotiation. But there's a way to do that. There's evidence-based ways to kind of get preferences from the start. And then together, because they are aligned with their preferences, then they have more power to communicate with the healthcare team those preferences and those goals. So that's sort of one idea, to try to start a systematic training that begins with goals of care from the beginning.
I do think people are empowered by the asking, the fact that you do ask. I think you have to then make sure that you ask and ask again, because some people are socialized or because of cultural reasons and so on, are going to give you the answer that you want to hear, or they don't really know how they could participate or how they might contribute. So you do have to be mindful of that as well, but I think that is a wonderful way to begin.
I agree with you, and also trying to educate providers too. I think sometimes there's overreaction to concerns about privacy and HIPAA concerns, and also time barriers to include the family. But I think those can be overcome with training too of the provider side.
The reason, thanks for your comments. I mean, the reason I raised that question in my presentation is actually because when we did that project with NCI on team-based care, we had 16 different writing teams that were working and each of those teams had clinicians, they had a patient, and they also had someone who was expert in team science, the sort of the soft aspects of looking at how care is delivered. And I think, one of the things that has been coming out more recently is isolationism can actually be quite damaging to people's survival. And so I think that piece of understanding where the patient is, do they have the support system that's going to help them get through this experience, is incredibly important. And I love your comment about working with people who have gone through, patient survivors who can then be involved as, and Courtney mentioned this in your comments as well, relying on the expertise of those patients who have gone through and come to the other side and then want to contribute really going forward. It's important.
I think what you said is so very important. I happen to work in a community where we built a community cancer center from scratch. And prior to putting pencil to paper to design our cancer institute, we met with community people for input as to how they wanted to receive cancer services. And we do have wonderful doctors and nurses, but I have to tell you, I think that the effectiveness of reaching our community came from consulting the community for their input and making sure there was broad representation before we started the project. So you really, your comments resonate with me. Thank you. Dr. Nguyen.
Yes, did you?
That's okay. If you want to go through a couple.
I apologize for missing that side. We'll do one there and come back here.
Yeah.
This is a question just about workforce. And I think that I'm reminded about Julian Richmond, who was part of the Head Start sort of program back in the day, who sort of said, these big ideals are probably right, but if it lacks political will, it can't get done. So I don't think that the assessment about going back to the pipeline, I think it's not an or conversation, I think it's an and conversation. But I think in part of that conversation, what was really missed was the political will and the resources of how do we connect with the NIH and others, including community, of building the pipeline. And part of that is actually reaching back to some of these communities that I really do think that you have to pay attention to, some of the high schools and even middle schools and things like that. So I would sort of say, as I look towards 2029, what I hope you did in 2009 is that we identified the issue. And in 2019, we're now going to identify how do we actually be better at executing the pipeline with a high school approach and later.
So I think that's a great point. And my only point was that can't be our only solution.
Absolutely.
Okay. At Penn, we actually do have a program that reaches in the high schools and tries to get them interested in cancer medicine, either basic biology or clinical medicine. And I think that's been a well-received and successful program. I'm just concerned that so much of our emphasis 10 years ago was we just need a lot more people and that'll fix the problem. And I don't think that's going to fix the problem.
I'm going to take the fact that you just invoked Julius Richmond to go a little further. All right. I think that what we need to do is go back toward Head Start. Many of the problems in the United States can be fixed by fixing third grade, okay? And one of the ways that we get ahead of ourselves in terms of this manpower problem is we actually start having cancer control and cancer prevention that starts in kindergarten, preschool, and finishes up at about third grade. And the end result is we decrease the number of people who actually need oncologic services in the long run. We need to, remember I said 5% of kids were obese in 1970 and it's 20% today. Fix that problem in grade school. Get kids interested in exercise. Get kids interested in eating vegetables and fruit and fresh fruits. And get kids away from smoking. Get kids away from all the other bad things and decrease the number of people who are going to need cancer services. Therefore, you decrease the strain that we're going to have on our economy.
Brenda, one quick comment, then we have another question.
So to do that, and even to entice young people in terms of any kind of healthcare career, I believe there's a partnership that needs to be done with the teachers of the United States and the counselors of the United States. Very few of our schools have full-time nurses in them. You saw what happened in California with the strike, and one of the conditions was they want nurses and librarians in their schools. Mm-hmm. So, there are partnerships that we could be looking at that, one, could address what Otis is talking about, because I can tell you, I think the teachers want to do the right things, but they've got a workforce issue themselves. Mm-hmm. So how do we come together? The other thing, I was on a public-private Workforce Commission in Durham, North Carolina, a number of years ago. And one of the aha moments, lessons for me, was I learned in that workforce that kids begin to decide what they don't want to be when they grow up by third or fourth grade. So they may not until high school decide what they want, but they start filtering things out. And it was a fascinating experience in terms of this workforce initiative and what we were doing with some of the private businesses and all. So we have opportunity. And I think that maybe there is a strategy, but those are going to be tough strategies. And why we are focusing on the pre-licensure nurses is we know they want nursing. They don't get much oncology content at all. So they're graduating with very, very minimal information about cancer as a disease and its treatments and the experience of patients. So that's why we're focusing now once they have chosen nursing. But the National Student Nurses Association is doing a lot of work in the school system.
And
Thank
again,
you.
just
Our
quickly,
next-
the only reason why I want to bring this up is that I don't want in 2019 for us to swing to technology and then kind of go, what about, it's a high tech, high touch and conversation, and I think we have to do to address this issue.
Our next person has been very patient.
Oh, that's fine. My name is Sarah Birkin, Assistant Professor of Health Policy and Management at the University of North Carolina. And I will just come out and say that my stake in this is, Larry presented a slide that talked about the number of patients increasing in his institution. I've seen anecdotes repeatedly from different institutions with these same increases. And my perception is that a lot of this has to do with survivors who have been cured of their cancer continuing to be seen indefinitely in cancer programs. And we have an opportunity to transition them away from oncology so that oncology providers can provide oncology care and not primary care. And so my question to all of you, because survivorship care plans have come up in some of what's been discussed, if not survivorship care plans, how do we take advantage of this opportunity to transition survivors who no longer require oncology care? And how do we take care of the oncology providers who rely on those survivors for their mental health?
So,
Larry.
So Sarah, it's a complicated question, as you know, because you and I have talked about this many times, and we are going to hear a little bit about potential models for survivorship care later on in the workshop. I have a couple of concerns. One is that there is an extraordinary workforce problem with primary care. Getting a primary care appointment in the Penn system or in the Harvard system, too, that I've lived in, you have to sort of give away your firstborn to get somebody a primary care appointment. And I realize it's variable place to place, but there are other workshops going on elsewhere in the country about how to manage the severe shortage of primary care doctors. And my other concern is that our survivors have very different needs. Some of them have very few in the way of oncologic needs, and some of them have a lot in the way of ongoing oncologic needs. And most of the primary care doctors are not equipped to ideally manage some who have the more severe short and long-term complications and really can't. They sit in their office trying to manage their patients with their diabetes out of control and their blood pressure out of control and many of the other issues. So I think it has to be a partnership. And I think, sure, we can get the primary care doctors. They need to take care of the non-cancer stuff, and sometimes they may be able to take care of the cancer stuff. But I do think it needs to be an ongoing partnership. And Linda will talk a little bit later about some potential models that are sort of, speak to both issues.
Sir?
I was just going to say that I think we're looking at this, and certainly in oncology, the concern about clinician wellness. But I think we also could think about this in terms of, are there different models that we could be looking at? For instance, the concept of the oncology care medical home has now come into oncology just like it was in primary care. But, these what we know about cancer patients is that they have a lot of, or at least those who are older, have a lot of comorbidities and challenges, as Larry notes, but we could also probably be thinking about grouping them differently. So for example, if we didn't just have oncology clinics that were distinct from cardiology, distinct from other disciplines, we might be able to have patients come in and be able to see a host of providers that are actually there to meet the needs that they're bringing in with them. So if we had, and one of the other things that we looked at, what we talked about in the context of the ASCO oncology workforce studies is things like group visits. Maybe patients wouldn't be opposed to thinking about coming to a group visit versus a one-on-one visit, especially for those who are in survivorship. I think making those connections is helpful as you're going through active cancer treatment, but it could also be helpful in survivorship as you're thinking about, different issues that are coming up. So I think there might be different models that we could look at that might also be helpful for the clinicians to connect with their colleagues from other disciplines and think about the whole patient and not just the patient who is in this cancer experience and also has arthritis and cardiologic challenges. I think we could think about things in a more holistic way also.
I apologize. We are out of time. Our speakers will be available over the break. I'd like to thank Otis Brawley, Suanna Bruinooge, Brenda Nevidjon, Courtney Van Houten, and Larry Shulman. And thanks for your attention.